Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. I want to start with a number, $4 trillion. Actually, if you use the newest federal numbers, it's now over 5 trillion. But the 4 trillion machine is still the right mental model because the point is not the exact decimal point. The point is scale. American healthcare has become one of the largest economic systems on Earth. If U.S. healthcare were its own country, it would rank among the largest economies in the world. It is bigger than the economies of many wealthy nations. It touches your paycheck, your taxes, your premiums, your local hospital, your employer's hiring decisions, and the long-term fiscal future of the country. And most people, including plenty of smart people working inside it, still do not have a clear picture of how the machine actually works. So today I want to make that machine visible. This is the first episode in a short series about how money moves through American healthcare, where it comes from, where it goes, why the system keeps getting more expensive even when patients, employers, doctors, and governments all say they are under pressure. And because this is Reimagine Healthcare, we are going to keep one eye on Southern Oregon the whole time. Because this is not abstract here. In Medford, Ashland, Grants Pass, and across the Rogue Valley, healthcare costs shape business decisions, household budgets, access to care, and the long-term viability of the institutions our region depends on. So let us start with the basic question. Where does all that money come from? At the national level, healthcare spending now runs a little above $5 trillion a year and accounts for roughly 18% of the entire U.S. economy. That money comes from four main places. First, households. That includes out-of-pocket spending, premiums people pay directly, payroll deductions for employer plans, and Medicare premiums. Households are not just paying a copay here and there. They are one of the major financial backers of the entire system. Second, private businesses. Employers still finance a huge share of coverage in the United States, which means healthcare is not just a health issue. It is a wage issue, a hiring issue, and a competitiveness issue for every local business trying to stay afloat. Third, the federal government. Medicare, the federal share of Medicaid, ACA subsidies, care for veterans, and the tax subsidy for employer-sponsored insurance all flow through Washington in one form or another. Fourth, state and local government. Medicaid matching dollars, public employee coverage, and public health spending all show up here. So when someone says the government should stop paying for health care, or, on the other side, employers are the ones paying for health care, the honest answer is both are true and households are paying too. This is a shared financing structure, which is one reason the system is so politically hard to change. Everybody pays. Nobody fully controls it. Now let us talk about where the money goes. The biggest category is hospital care, then physician and clinical services, then prescription drugs. The newest CMS breakdown puts hospital care at about 31% of spending, physician and clinical services at about 21%, and retail prescription drugs at about 9%, with the rest spread across nursing care, home health, dental, administrative overhead, insurance margins, and everything else required to make the machine run. And that last category matters more than most people realize. The United States spends an extraordinary amount on administration. Depending on how researchers define it, administrative spending accounts for roughly 15 to 30% of total health spending. That includes billing complexity, coding, prior authorization, insurer overhead, compliance work, and the armies of people required to make a fragmented, multi-payer system function. Not all of that spending is waste. Some administration is necessary. But the American system clearly burns more money on bureaucracy than peer countries do. That is not a side issue. That is one of the core design features of the machine. So now we have a first sketch. Massive flows of money coming from households, employers, and government. Massive flows going to hospitals, clinics, drug companies, and administrative layers. The obvious next question is, how did we build something this large? The answer is not one bad law or one villain. It was a series of decisions that made sense in the moment, then compounded for decades. One of the early building blocks was the Hill-Burton Act in 1946, which helped finance a major expansion of hospital construction across the country. America wanted more hospital capacity, and it got it. Another was the growth of employer-sponsored insurance, supercharged by the tax exclusion Congress clarified in the 1950s. If your employer pays you in wages, that is taxable. If your employer pays for your health insurance, that compensation is treated more favorably. That tax preference became one of the biggest subsidies in the entire federal tax code and helped make employer coverage the dominant model. Then came Medicare and Medicaid in 1965, which brought the federal government in as a much larger long-term payer. Each step had a logic to it. Build hospitals so people can get care. Tie coverage to employment so families are protected. Cover seniors and low-income Americans so illness does not automatically mean destitution. Those were not crazy decisions. In many ways, they were morally serious decisions. The problem is that the system they created was never designed for what came next. It was not designed for decades of chronic disease growth. It was not designed for an aging population. It was not designed for blockbuster specialty drugs priced at tens of thousands of dollars per patient per year. It was not designed for a dense forest of billing rules, coding systems, contracts, and intermediaries, and it was definitely not designed to deliver clear consumer price signals. That brings us to one of the most important ideas in this entire series, and I want to explain it in plain English. Moral hazard. Moral hazard does not mean people are immoral. It means people behave differently when someone else is absorbing most of the cost. If you had to pay the full cost of every MRI, lab panel, consult, infusion, and hospital visit directly out of pocket, you would think about utilization differently. So would your employer. So would the insurer. So would the provider organization building capacity. But in American healthcare, the direct consumer share of spending is relatively small compared with the total system. CMS data show out-of-pocket spending is only around 11% of national health expenditures. Most of the time, patients experience health care through a third-party payment structure, employer plan, Medicare, Medicaid, commercial insurance. That arrangement protects people from catastrophe, which is good, but it also weakens the normal price sensitivity that constrains spending in other parts of the economy. And once you combine reduced price sensitivity with tax subsidies, regional consolidation, fee-for-service incentives, drug pricing power, and chronic disease, you get a machine that keeps expanding almost regardless of whether the outcomes justify the cost. That is the key point. American healthcare is not expensive because one group is greedy and everybody else is innocent. It is expensive because the incentives compound in one direction. Hospitals are rewarded for scale. Drug makers are rewarded for breakthrough products with pricing power. Employers are rewarded up to a point for offering coverage through a tax-favored channel. Patients are buffered from full prices. Politicians get punished for cutting benefits, and rarely rewarded for long-term cost discipline. And providers operate inside a payment architecture that often pays better for intervention than prevention. That is what a machine looks like, not one evil actor, a structure that keeps generating the same outcome. Let me make that even more concrete. Imagine a local employer in Medford. Premiums rise again this year. The employer responds by shifting more cost to workers through deductibles, coinsurance, or narrower networks. Employees then delay care because the upfront cost feels painful. They show up later, sicker, and more expensive to treat. Claims rise. Premiums rise again. The employer concludes that workers are overusing care. Workers conclude that insurance is useless. The hospital concludes it is underpaid. The insurer concludes the hospital is charging too much. And every person in that loop feels, from their own vantage point, like they are reacting reasonably. That is how systems trap people. Nobody has to be crazy. Nobody has to be evil. The structure just keeps reproducing the same pressures. You can see the same thing with public spending. When Medicare, Medicaid, and subsidized private coverage expand, more people can access care. That is good. But if the underlying prices remain high, the public cost rises too. Then elected officials argue about the federal deficit without admitting that healthcare cost growth is one of the engines underneath it. We end up fighting about the bill without fixing the machine that keeps sending the bill. And then there is the patient experience itself. Most people do not encounter the healthcare economy as an economist. They encounter it as confusion. Why did that lab get billed separately? Why was the hospital in network, but the anesthesiologist was not? Why does a medication cost one amount in January and another amount after the deductible is met? Why does a simple imaging study have 4 different prices? One sticker price, one negotiated rate, one cash price, and one final patient responsibility. That confusion is not accidental background noise. It is part of the cost structure. Complexity changes behavior. People avoid care they need, accept bills they do not understand, and struggle to compare options intelligently. A normal market depends on intelligible prices. American healthcare often gives people price information after the fact when the decision has already been made. So when I say the machine is structurally expensive, I mean it at multiple levels. It is expensive because of what we buy. It is expensive because of how we pay. It is expensive because of who has bargaining power. And it is expensive because the average person cannot see clearly enough inside the system to discipline it with normal consumer behavior. Now let us bring this down from Washington to Southern Oregon. Why does this matter here? First, because our region has real health challenges. County health rankings consistently place Jackson and Josephine counties in the lower half of Oregon counties on overall health outcomes and health factors. Second, because chronic disease is common here, and chronic disease is what turns healthcare spending from episodic into permanent. Obesity, diabetes, hypertension, sleep apnea, arthritis, depression, substance use, and cardiometabolic disease are not one-time expenses. They create recurring utilization across years or decades. Third, because this region does not operate in a highly competitive hospital market. Asante is the dominant hospital system in the Rogue Valley, with major facilities in Medford, Grants Pass, and Ashland. That matters because when markets consolidate, price negotiations tend to happen from positions of regional leverage rather than from open competition. That is not unique to Southern Oregon. It is a national pattern, but we feel it locally. Fourth, because local employers are small enough to feel premium increases very directly. A big national employer can spread costs across a giant workforce. A small manufacturer in Medford, a construction firm in Central Point, or a family business in Grants Pass feels those increases in a much more intimate way. Premium growth means lower wage flexibility, harder hiring, and sometimes dropping coverage altogether. Fifth, because Southern Oregon has the exact kind of population profile that makes this machine harder to finance. We are older than many metro regions. We have meaningful rural access challenges once you get outside the main corridors. We carry a significant chronic disease burden, and we have many households and small businesses that do not have much margin for error. That means the same national cost growth does more damage here than it does in a richer, younger, more competitive urban market. So if you are a Southern Oregon listener wondering, why should I care about $5 trillion in Washington when I'm just trying to keep my family insured? The answer is because that national machine lands in your life through payroll deductions, deductibles, employer decisions, taxes, and local access. It also lands in less obvious ways. It lands when a small employer decides not to hire another person because benefit costs are too high. It lands when a school district has to budget around rising employee health costs. It lands when a county government spends more on benefits and has less room for everything else. It lands when a family keeps working a job they would otherwise leave because the insurance is too hard to replace. That is what economists call job lock, and it matters more than people think. When health insurance is tied tightly to employment, healthcare costs do not just shape medical decisions, they shape labor mobility, entrepreneurship, and the willingness to take risk. In a region that needs resilient local businesses, that is a real constraint. And there is another layer. American healthcare is very good at certain things. It is very good at high-end rescue medicine, trauma care, complex surgery, ICU care, advanced cancer treatment, interventional cardiology. When the house is on fire, we can be extraordinary. What we are much worse at is building a payment and care model that reduces how often the house catches fire in the first place. That is why chronic disease matters so much in this story. The system makes money more easily from managing established disease than from quietly preventing it. A stent has a billing pathway. A hospital admission has a billing pathway. An infusion drug has a billing pathway. 3 years of patient coaching, nutrition support, behavior change, and early metabolic intervention is much harder to fund, measure, and scale. That does not mean no one cares about prevention. Plenty of clinicians do. Plenty of health systems say they do. Some payer models genuinely try. It means the machine, as currently built, still leans downstream, and that is one reason cost keeps rising. Now, I want to pause on one common misunderstanding. People often talk as if healthcare spending is just a healthcare problem. It is not. When healthcare reaches nearly 1/5 of GDP, it becomes a whole economy problem. It affects federal deficits. It affects wage growth. It affects entrepreneurship because leaving a job can mean leaving your insurance. It affects school districts, county governments, and nonprofits that are trying to cover employees. It affects what employers can invest in besides benefits. In other words, healthcare does not just consume medical resources. It competes with everything else we say we value. That is why I called this episode the 4 trillion machine. Not because the number is magical, because the scale changes the meaning of the system. Once something gets this large, it is no longer just a sector. It becomes infrastructure. It becomes political gravity. So, what should listeners actually do with this? Let me give you a few practical ways to think about it. If you are an individual or family in Southern Oregon, start paying attention to the difference between insurance and care. Those are not the same thing. Ask what your plan actually covers, what your deductible really means, where your lowest cost, high quality options are, and whether your primary care relationship is helping you prevent downstream problems instead of just reacting to them. If you are an employer, treat healthcare like a strategic business cost, not a passive line item. Ask how premiums are trending. Ask what is driving claims. Ask whether your employees can access primary care, behavioral health, and chronic disease support early enough to avoid higher cost crises later. If you are a clinician or health system leader, ask a harder question than whether your organization is busy. Ask whether it is moving the region upstream or downstream. Are you reducing avoidable chronic disease burden or mostly getting more efficient at processing its consequences? And if you are a local policymaker or civic leader, stop treating healthcare cost as someone else's issue. It is an economic development issue, a labor market issue, a county budget issue, a family stability issue. That is the decision support takeaway from this episode. Do not think of healthcare only as what happens when I get sick. Think of it as a financing system that is already shaping your choices, whether you engage it consciously or not. Let me turn that into a simple what you can do list. If you are choosing coverage during open enrollment, do not just compare premiums. Compare deductible exposure, network breadth, drug coverage, and where your current doctors and local hospitals sit in the network. If you live with a chronic condition, ask a brutally practical question. Which part of my care is likely to generate preventable downstream cost in the next 2 years? Medication access, poor follow-up, untreated sleep, unmanaged blood sugar, delayed physical therapy, untreated depression, lack of transportation, whatever it is, find the choke point early. If you run an organization, ask for data instead of slogans. Are emergency visits rising? Are specialty drug costs driving claims? Are employees using primary care and behavioral health? Is absenteeism tied to chronic disease? Vague frustration is not a strategy. And if you are someone who wants to improve healthcare in this region, start learning the local institutional map. Know who pays for what. Know which problems belong to Asante, which belong to insurers, which belong to employers, which belong to county and state policy, and which belong to the upstream conditions of daily life. Clear thinking starts with correctly locating the problem. That is how this series is meant to help, not by giving you one magic reform, by helping you see the machine clearly enough that your decisions become less reactive and more strategic. So here's the one thing I want you to remember. American healthcare is not just expensive. It is structurally expensive. It got that way through decades of reasonable decisions that compounded into a system with weak price signals, powerful intermediaries, strong regional concentration, heavy administrative overhead, and a chronic disease burden it was never designed to handle. And Southern Oregon is not outside that story. We are inside it. In the next episode, we are going to zoom in on one of the most distorted parts of the whole machine: prescription drugs. Why the United States pays far more than peer countries for many medications. Why Medicare was blocked from negotiating drug prices for so long. And why that matters not just nationally, but to families, employers, and public budgets, right here in our region. If you want help thinking more clearly about healthcare in Southern Oregon, subscribe to the newsletter at reimagine-healthcare.org. That is where I break these issues down in plain English, connect the national story to local realities, and give you practical frameworks you can actually use. This podcast is for educational purposes only, not medical advice. If I got something wrong or left out an important perspective, reach out through reimagine-healthcare.org. I want the conversation to get sharper, not just louder. Thanks for listening.